Okay, our next speaker is Nicole Provenza from Baylor College of Medicine. She's going to be talking about the ethological neurobehavioral investigations in obsessive-compulsive disorder.
Hi, everyone. It's really an honor to be here. Thank you. I am very excited to be the caboose on our really exciting morning session. And what I'm going to be talking about is our recent work using real-world on DBS device recordings to identify a biomarker of clinical response after deep brain stimulation for OCD. So before I get into it, I want to acknowledge our awesome team at Baylor College of Medicine and our collaborators that made this work possible. And it was led by Samir Sheth in neurosurgery, Wayne Goodman in psychiatry, along with our big teams in both of those departments, and then our collaborators at the University of Utah and the University of Washington. So obsessive-compulsive disorder, OCD, is a psychiatric illness marked by obsessions, which are recurrent distressing thoughts, and compulsions, which are repetitive ritualistic behaviors. And OCD can be really debilitating. Many patients experience severe comorbid depression and anxiety and are unable to attend work and school. And one of the things that I like to say to make OCD a bit more relatable to people that might not be familiar with it is that you know the alarm bells that you might hear in your head after you realize, oh, I probably forgot to unplug my iron, or I left my stove on, or maybe my front door is not locked. And then you go back and you check and you make sure, and most of the time you probably did remember to do that thing. Well, for people with OCD, these alarm bells and that sudden feeling of fear, it's constant. It never goes away, even after you go back to check, or even after you lock that door. And you just have this, terrible feeling that never goes away, and you know that it's irrational, but you can't stop checking, you can't stop doing the thing that OCD is telling you to do. So yeah, this can be really debilitating. It has a lifetime prevalence of 1 to 3%, and 20 to 40% of OCD patients are treatment resistant. So in a meta-analysis done by our group, we evaluated the efficacy of deep brain stimulation for refractory OCD. And this included 34 studies, 352 patients, and we found that 2 out of 3 patients met response criteria. And I want to emphasize that these patients have not been responsive to anything else that's out there, medication, psychotherapy. So the conclusion is that DBS works really well in this treatment-resistant population. It produces clinical response in 66% of otherwise treatment-resistant patients. So that's really great news. DBS works in OCD. But again, this is only in 2 out of every 3 patients, and clinical response is defined as a 35% reduction in symptoms. And that's not the same thing as remission. So there's still a lot of work to do. So the goal of DBS programming is to improve OCD symptoms without inducing side effects. So if stimulation amplitude is too low, you still might see OCD symptoms, which include distressing thoughts, ritualistic behaviors, pathological doubt, and feelings of incompleteness. But if it's set too high, you start to see disinhibited behaviors, including recklessness, elation, increased libido, and impulsivity. So you don't really want to be on either end of the spectrum, you want to be in the middle. And so with acute stimulation, so we do intraoperative awake stimulation testing during the surgery to optimize lead placement. And something that we look for is an increase in energy and motivation, an increase in mood, and we think that this is a good sign, and this helps us figure out where exactly to place the lead. So I'll show you an example of what this could look like in this video.
Whoa, okay. Yeah, I mean, like an 11 out on a scale of 1 to 10. That was something.
It's good though, right?
Yes, something very good.
What do you feel like doing?
Jumping out of an airplane.
With a parachute?
With a parachute, yes.
So we get these kind of exciting acute responses that we really like to see, and we think that this is going to move the patient in a positive direction, away from OCD symptoms, maybe toward disinhibited behavior, but not all the way over the edge. And we see this both in the OR with acute stimulation and during programming sessions, during the first programming session and later. And here's an example in the clinic.
That was kind of cool. I don't know, that was a good little jolt. Whatever that jolt was, I like that. Do more of those jolts.
And so something that we've started to call this behavior is approach behavior. And what we mean by that is we see increased engagement in conversation. The patient might point at something on the wall and say, hey, did you notice that? They start to talk a lot more, and facial expression becomes more animated. If we see that the behavior is kind of developing into something a little bit that looks like hypomania, so like pressured speech, like you can't get a word in, we actually do turn stimulation amplitude down before the patient goes home so that we can avoid getting the patient into a hypomanic state, which is not healthy. So the current DBS programming paradigm is open loop, meaning that patients come into the clinic, DBS gets turned on or amplitude is increased, and they might say, I think I feel better. I feel pretty good. They go home feeling great. Over time, OCD symptoms, come back. They realize OCD is really still there. They go back to the clinic weeks to months later, and they don't feel better. And one thing I want to stress is, two things. DBS programming is really high burden on both patients and clinicians because OCD symptoms don't get better right away with these acute effects. It actually takes weeks, months, sometimes over a year for OCD symptoms to improve. So this is a really stressful, time-intensive process for both the patient and the clinician. So we want to propose that remote detection of clinical states could enable data-driven intervention that would allow for a faster programming process that is really lower burden on the patient and the clinician. So our recent work focused on identifying neural biomarkers of long-term clinical response. So clinical response in OCD is traditionally assessed using the Yale-Brown obsessive-compulsive scale, or the Y-box, which is a clinical assessment where you ask the patient how they did over the last 2-week period. And it's a rating scale. So we wanted to identify a neural biomarker of response by continuously monitoring neural activity in the real world. And the real world part is really important. I don't have to convince all of you here, but really real life happens mostly outside of the clinic, like nearly 100% outside of the clinic. So it's really important that we capture these neural activity patterns in the real world. And so this paper was published in July, just like about a month ago, in Nature Medicine. And I want to acknowledge my co-first authors, both medical students at Baylor, Sandy Reddy and Anthony Allam, who were amazing partners on this work. So our hypothesis is that the states that we want to identify, OCD, disinhibition, healthy approach behavior, they lie on a continuum, where OCD is represented by pathologically avoidant behavior. On the other end of the spectrum, with DBS of the ventral capsule and ventral striatum, you start to see disinhibition, and in between lies healthy approachful behavior. And so our goal was to identify neural biomarkers of these states. So in a cohort of patients that had DBS leads implanted in the ventral capsule and ventral striatum, we started recording local field potentials during surgery, and this went on until stimulation was turned on, and then for, in a lot of cases, months to years after deep brain stimulation began. And we had one cohort, an N of 5, 3 responders, 2 non-responders, where we had a very complete data set. Like I described, from the time point of surgery to months to years after surgery. In another cohort, we applied the models that we developed in the first cohort to 7 more patients that had a less complete data set. Maybe patients had a battery replacement years after DBS where they suddenly had the device that was recording capable. Every patient had a different explanation of why they had less data. So in our few first patients, we identified a narrow peak in the 9 hertz frequency band, and we were able to use the Medtronic Percept device to track 9 hertz power continuously in 10-minute intervals, 24/7 essentially. So this is not time domain neural data. This is power in the 9 hertz band in 10-minute intervals continuously. So first, I want to show you data from the non-responders, but let me take a moment to orient you to these plots. So we have time of day from midnight to midnight on the y-axis. And on the x-axis, we have days since DBS activation, where DBS on happens at the vertical pink line. And our color scheme labeled at the top, yellow is severe OCD symptoms, and purple is severe OCD symptoms after deep brain stimulation. And so the colors here show 9 hertz power. And you can see that there's a peak in brighter blue that happens at around 4 a.m. and a trough that happens around sometime in the afternoon. And we call this a neural circadian pattern. So this neural circadian pattern appeared before DBS, and then after DBS was turned on, there's really no change. It's pretty stable over the entire monitoring period. And in our second non-responder in the first cohort, we saw the same trend. Neural circadian pattern, no real change. We quantify this by fitting a cosine function to that pattern. And what I'm plotting here is amplitude and phase, so the time of day that the 9 hertz power peaks. So in the severe OCD symptom state, you can see that the yellow dots are all clustered at a similar time point. It's peaking at the same time of day. After DBS, it's very similar to the pre-DBS state. So the conclusion here is that non-responders show a distinct, consistent neural circadian pattern that does not change after DBS. But in the responders, something really exciting happened that was really different. So before DBS, we see a similar neural circadian pattern, just like the pre-DBS state and all the other patients. After DBS, we see that this pattern evolves into something that looks completely different than the pre-DBS pattern. It's higher entropy. There's still a peak, but maybe it's at a different time of day. But the circadian pattern is definitely not as strong. And we saw that this pattern held up in all 3 responders in our initial cohort. And looking at these polar plots, you can see again, like the yellow dots are all pretty self-similar before DBS, but blue dots representing response after DBS either have a reduced amplitude or totally different phase that really distinguishes the clinical response phase from the pre-DBS severe symptom phase. So the takeaway here is that in responders, the neural circadian pattern is significantly disrupted after DBS. And here I'm plotting the data in a slightly different way. So I averaged all the days that we had in each of the zones. So pre-DBS severe symptom is yellow. And you can see in the non-responder, this is very lobed, very circadian. And after DBS, when we still have symptoms, not much changes. And in the responder, again, pre-DBS is very lobed, but you can see in the blue zone, there's still a circadian pattern, but it's very, very reduced. And so this video shows you on an individual day basis what the data looks like. And so pre-DBS, you could see, it was very lobed. After DBS, it starts getting really high entropy, much more spiky. The neural power is very dispersed throughout the day. It becomes very unpredictable. Maybe you could say more flexible. And ultimately, we quantified this by fitting a linear autoregressive to the model where we wanted to predict the future points from the past data points. And what we found is that the R-squared, the goodness of fit, was very high in the pre-DBS state. And after DBS, in responders, the R squared pretty much tanked. So it became very unpredictable. And that kind of fits with our high entropy theme. So symptom improvement is associated with unpredictable and high entropy theta alpha power over a 24-hour period. Here I'm showing, in the bottom plots that are showing right now, the raw data is in gray, the linear autoregressive fit is in green. And in those 3 example days on the left, you can see that the linear autoregressive fit really tightly covers up the true data. But on the right, you can see that the fit is doing a pretty poor job. You can see that there's a lot of high amplitude peaks that the fit is not capturing. And so that's what's really representing the decreased R squared after clinical response. And so looking at the 5 patients in our initial cohort, 3 responders and 2 non-responders, you can see that there was a significant difference in this linear autoregressive R squared after clinical response in the responders, but not the non-responders. So when we plot the mean pre-DBS R squared and post-DBS R squared, you can draw a line by a very narrow margin between symptomatic state and unsymptomatic state. So then our reviewers wanted to see that this result replicated in a larger sample size. So we added 7 more patients, 3 of them thanks to our collaborator Ben Chofty at the University of Utah. And I was pretty amazed to see that, it worked. We were still able to distinguish responders from non-responders given a single day of neural data just by computing the linear autoregressive R squared. So we trained a logistic regression model using data from all our patients, and we found that we were able to predict symptom days versus clinical response days with about an 82% accuracy. So in summary, we identified a neurophysiological biomarker of clinical status after DBS for OCD. I'm really excited because this device is commercially available, which means that other groups will be able to collect the same data and see if this holds up in a larger sample size. So our central feature was neural predictability. After response, predictability kind of tanked. And so we think that DBS facilitates this pro-approach behavior, which might be necessary for clinical response. And we think that it helps people overcome the avoidant phenotype characterizing OCD. And I hope that these biomarkers could enable data-driven intervention, where stimulation adjustments based on clinical status of the patient, as measured by on-device recordings, would be delivered in a remote kind of closed-loop way. So I want to spend my last couple of minutes talking about really how this work has totally changed my view of biomarkers in psychiatric disorders and where I think we're going next in the field. So I want to show you a video that was made by another group, Feldman et al. In 2021. And this is of the beta band marker in Parkinson's disease. And beta band is a really well-known marker of motor symptoms in Parkinson's disease. You can see that it's really high right now. DBS is off, and she's struggling to do this hand open, hand closed task. So right after stimulation is turned on, you can see that beta band immediately goes down, and she's able to perform this task a bit better. And so essentially, beta band in Parkinson's disease, I think, has kind of really generated enthusiasm for on-device DBS recordings and potential closed-loop DBS strategies. This is an extremely satisfying demonstration of a biomarker that, immediately goes down when symptoms go away. And I don't think that's necessarily how it works for psychiatric disorders. But over the past 5 years in OCD, several groups have been trying to find, the psychiatric equivalent of beta. We, in my paper in 2021, in an N of 3, looked at acute OCD-related distress and recorded local field potentials, and we found that increased delta correlated with lower OCD distress. Miller et al. In 2019 before us, in an N of 1, found that symptom provocation was related to increased gamma activity in the nucleus accumbens, so very different from what we found. And more recently, the group at the University of Pennsylvania in an N of 1 found that OCD obsessions are related to increased low-frequency activity, all the way spanning from like delta, I think, to high alpha or low beta. And then the MGH group found in an N of 2 that actually it's alpha. Alpha suppression correlates with Y-box symptom improvement. So, there's been a lot of heterogeneity in terms of the results that we found when we try to relate neural activity to symptom state. And I think maybe when we only look at like a snapshot of neural data, maybe we're looking in the wrong place. Maybe we need to look at longer time scales. And so our recent work found that variations in the baseline are actually markers of slowly evolving states, such as recovery after DBS for OCD. And so the takeaway that I want to move forward into my future work is that neural biomarkers of slowly evolving clinical states relevant to psychiatric disorders might not be episodic variations from the baseline, but features of variation in the baseline itself. And I think this idea is picking up steam. Before us in 2023, Alagapan et al. In a cohort of 10 patients with DBS for depression found something similar, where they're tracking this neural biomarker over time, and they are actually able to predict when someone is kind of descending into a depressive state even before the patient themselves know about it. So, where are we going next? There's 2 devices that are currently available in the US, the Medtronic Percept PC and NeuroPace RNS, that can do these on-device neural recordings. But more and more are being developed all over the world. And I want to pair these neural recordings with behavioral recordings from wearables. So Apple Watch, iPhone and mobile apps, Whoop Band, Oura Ring, Dream Headband, Fitbit. I'm really excited to use all these things and synchronize the behavioral data that we can get from wearables with our neural recordings. We've started to do this with Oura Ring in our OCD patients, and we chose Oura because it's a very small form factor, and we're really interested in capturing as much data as possible every day. A lot of patients like to take their Apple Watch off at night, but they will wear a ring throughout the night. So we've had a lot of success with that, and we've seen some interesting correlations between sleep time, which is shaded in gray, and neural activity, which is shown by the yellow and blue lines on the plot. And for people wondering, is this just movement artifact? Maybe patients are moving around more, and that's causing this unpredictability in our neural data, and this isn't really neural. Well, we see that at least in the left hemisphere, the blue line, during sleep, that's actually when our neural activity peaks. And we know that during sleep, this patient isn't moving. I'm not showing the activity data here, but you can see that activity is very low during sleep. So I don't think that this effect is driven by movement. So ultimately, the vision is data-driven intervention, where data is being continuously collected at home, both neural and behavioral, sent to the clinician. Maybe a clinically relevant state is detected, and then the clinician makes the decision: do I want to change stimulation parameters? Do I want to bring the patient in? Do I want to start a medication? And then they can act on that data. And before I take any questions, just want to acknowledge my growing lab at Baylor. Thanks so much for your attention.
We have time for questions.
Yeah, thank you for this very interesting talk. I think it's very impressive to monitor patients for that long. I was wondering what your interpretation is of the 9 Hertz marker. So why is that relevant for OCD symptoms?
Yeah, so we have a couple of theories. We know that in OCD, ventral striatum, well, in general, the ventral striatum handles reward processing, like both before and after rewards. And one theory that we have is that maybe reward processing in OCD is very like inflexible, and the kind of cyclic pattern of neural activity that really doesn't have any spikes before response represents like a limited behavioral repertoire, like limited number of responses to any given situation. And perhaps the unpredictable, like spiky activity after a response reflects more adaptive reward processing. But these things remain to be, explored.
Thanks.
Hi, Nicole. Beautiful data. Congratulations. Sort of thinking of my question as I'm standing here, which is if you can expand a little bit more on how you would use this information to adjust from a clinical side, given that these are longer timescales and they're not acute changes. In your data, is there any evidence for stimulation on a shorter time period having these kinds of effects that you can read out and adjust, or is it really just going to be trial and error at the clinician, with the clinician sort of, and the patient at home? What do you think?
Yeah, that's a great question. Right now, we're working on developing a clinician-facing dashboard that can take in our neural and behavioral data and, plot the features that we think are important. I think we could use it in 2 ways. One is to identify hypomanic periods after initial stimulation by looking at maybe periods where the patient stops sleeping as much. Another would be to track our, biomarker of response. We have in one patient that is still a non-responder, tried, because we haven't been able to come up with a stimulation paradigm that makes her better. On the device, you can program a couple of different options for stimulation. And so, that might include a different contact, a different pulse width. So we've given the patient access to 4 options. We record for 2 weeks on, the first option and then see, is the biomarker going in the right direction? If it is, we would leave it there. If it's not, we need to change. So I think in that sort of case, we could kind of cycle through. But I think one important next step on my list is to, instead of looking at clinical response and OCD as like a binary, try to relate the neural activity on a spectrum. So that way we can really tell okay, what behaviors and what neural activity patterns are moving in the right direction versus not.
Very nice. Thank you.
Thank you for this lovely presentation. Beautiful data. She was right. A couple of things that occur to me. One is in the longitudinal data, what do you see in the patients that you're treating and are responding? Is there a pattern that you see in terms of consistency in the biomarkers' presence? So are they learning something, and is that something feeding back into their? And then the second thing I thought is, does this beg some animal work to look more into this question?
Yeah, I'll start with your second question first. I think a lot of these, the question that you asked would be really interesting to explore in an animal model. I know that there's models of OCD in mice, if we recorded for several weeks in a mouse, I don't do animal work, so I'm uncomfortable with talking about this, but, what would the circadian patterns look like? If we could make them better, what would that look like? Would it also be unpredictable? Yeah, I think that's a really exciting next step. And then your first question, I think was about how are the patients changing behaviorally on their trajectory from sick to well. And we need to look at that more. I mean, I didn't expect much, honestly, when we started doing these recordings. We just started collecting the data, and I was kind of like, oh, it's not my time domain data. Like, I'm a bit of a time domain snob. What are we going to see? So we didn't do a good job of collecting behavioral assessments, and these patients aren't a part of a trial. They get DBS through insurance. So everything that we do, we try to do it passively. So that's why we're adding more wearables now. We have some patients that are like super responders and are basically remit right away, and some patients it takes a long time for them to get better. And if we had behavior on that, I think that would help us understand the period that I call the unlabeled period between symptoms and clinical response. Thanks for the question.
Really nice work. You mentioned the circadian rhythm being a really key component of the story and what's going on. And I know that in these patients, stimulation is often constant, right? Especially if the adaptive parameters are usually not very responsive on the circadian cycle. So I'm wondering if you could speculate how you potentially could use a more circadian responsive stimulation, especially because that's one of the strongest signals you have in these patients, and how you would do that, and if you'd expect the biomarker of interest to move in a certain way in response to that.
Yeah, so to rephrase it, you're wondering about doing circadian adaptive DBS for OCD. Yeah, so I love that idea. So one of the things that OCD patients with DBS struggle with is, since there's this energizing effect of initial stimulation that can lead to disinhibited behaviors in hypomania, a lot of patients can't fall asleep, especially in the initial weeks to months after DBS is activated for the first time. And so it would be interesting to try to use the neural data to figure out okay, when is the patient asleep, or when should they be falling asleep? Can we turn stimulation amplitude down? Because it's this careful dance between making sure it's high enough during the day so that we start to see these positive effects, but turning it down at night. I think in terms of using the circadian rhythm as a longer term symptom improvement signal, I think we need to be better, or have better biomarkers of disinhibited behavior, because really what I've seen is we want to have DBS amplitude as high as possible without inducing those side effects. So if we could figure out when is the time to increment up, then I think we would get rid of a lot of that high burden programming. And then the problems that come when you have a programming session at the wrong time, or not one at all when you need one.
Okay, before we thank Nicole, I just want to let people know we have about almost 15 minutes for a general panel. So at the end of each session, we're going to continue the discussion, open it up more broadly. I want to invite the other two speakers, maybe ask Nicole, grab that microphone, bring it there. The previous two speakers, please come on up. And so while they're coming up, just give you some ideas of things we can discuss. So we had three great talks, different clinical conditions, using EEG, FNIRS, and deep brain recordings and stimulation. They were all moving towards and in real-world settings. We did hear some discussion about going back to lab recordings to kind of confirm some of the results, but also at the same time we want to be pushing the real-world measurements. We're all here because we want to push those real-world measurements further and further, so we can have some nice general discussion about balancing real-world versus lab-based discussions, biomarkers for different clinical conditions. We can have more general discussion about that, and then of course I'm curious about, we're pushing these everyday recordings further and further. How do we bring that back to Uri's talk at the beginning of the models of the brain? Something we should all be thinking more about. So come on up to the microphone. And yeah, here's one.
It's a long walk for me on the other side. I actually find it very interesting that you all talked about biomarkers in some form or the other, and I guess I'm wondering, why is it important to find that? I think I heard some of that at the last question answer where it helps with that treatment, but why do we need to know? They all look like they're different signatures, and I mean, the thing that I can relate to is the stroke cognitive effort, but you're talking about a circadian rhythm that at some level aligns with the behavioral response or not. So can you tell us why we should focus, in your own opinion, your own field, on biomarker discovery, and how you think it actually pushes the clinical piece forward in your own field?
I'm happy to start. So in psychiatric disorders, I think it's really hard to like we don't have objective labels for, necessarily for like what well is, or even like how to diagnose like one disorder versus another. I think all we can do is ask patients how they feel. And there might be more going on kind of underneath the surface than we're able to observe. So I think it's really helpful to have an objective readout of what healthy is. And like just to know, I guess, like diagnosis and evaluation, but also to develop better therapies. Like how do we get that there faster? So, it's kind of like the in an optimization function, like the objective of that.
Yeah, I think that's a great question. I wanted to say I'm glad you asked it, because I felt like that was a point I didn't hit hard enough in my talk. So for rehabilitation specifically, and especially the rehabilitation of walking, we're just starting to understand the neural signatures, even of healthy gait. Obviously, I talked about, there's been decades of confusion and sort of back and forth about what even is controlling gait, but we're just starting to understand those cortical signatures. So in terms of biomarkers for my field, we would love to start to delineate biomarkers of, propensity for rehab to succeed. So to start to identify markers of who would be a good candidate, so we can maximize our time and our effort towards enhancing neuroplasticity. And then we also would love to see and to understand better biomarkers of successful rehabilitation. So what does that look like, and how does that interact with sort of in cerebral palsy? How does that interact with subtype? How does that interact with our pre-therapy biomarkers? So that would be the ideal. If we could sort of get in early, we could say this person has this subtype and has this propensity to regain some function, and then we could really intervene in the first few years of life when that neuroplasticity is maximal.
Yeah, I think just to add to what you said, in stroke, it's a disorder of the brain, and so it just makes sense for us to be looking at what's happening at the brain level. And so because we know gait is obviously very impaired, and that's a primary focus of neurorehabilitation, but to develop the right interventions and to prescribe the right interventions at the right time for the right person, I think we really need to understand what's happening and why these dysfunctions emerge. So, yeah.
All three of your talks are really amazing. Kind of something that I saw with all three of you is that there was obviously people that were either responders and non-responders. So I was wondering, like, if you were either to replicate this, like, a study again or the experiment, what kind of measures would you maybe take of pre-screening that maybe you saw, like, in some of the patients that were non-responders, to kind of make sure you get a more vast data set of, like, oh, it's patients with maybe like a stroke, but with specifically these variables that we saw a response in, or I guess with like with you guys too, like what are specific signs of like OCD or cerebral palsy that you saw were like that you could easily more pre-screen for like patients in the future?
So we kind of used it to our advantage that we expected to see some people be non-responders, and so because this wasn't necessarily a therapeutic study, we were okay with that. But in the future, we'd like to be able to take different phenotypes, or let's say, for instance, something like how their baseline walking is, their baseline propulsion symmetry. So maybe the people who are more symmetrical at baseline are responding differently, things like that. But for the purposes of this kind of more mechanistic work, it really, that spread was more helpful for interpreting our results. So, yeah.
I'm in the camp where I think there must be something going on that distinguishes non-responders from responders in DBS for OCD, and that we have to be able to figure out before we implant someone who's going to be a good candidate. We have some theories, but none of them seem to be working out completely. I think what we need is a big data set with lots of multimodal data. Maybe it's something about the OCD subtype, maybe it's something about the way the brain works. One idea that we've had is like some groups in Parkinson's disease mostly actually implant the DBS leads and externalize the leads and do, maybe a couple days of recordings with stimulation testing before they implant the battery that goes in the chest. If we could do that, and if we had some sort of marker of like, oh, stimulation happened, neural activity did this, we know this person's going to be a responder or not, then in the non-responders, you could just take everything out. I mean, this also would be like sad to remove the opportunity completely of getting better after DBS, but at least, they would know, okay, this isn't the right therapy for me. I need to search elsewhere. I'm not going to spend years in programming sessions traveling across the country to expert centers to get this done.
Mm-hmm. And for my particular population, they tend to have an actual neural injury. So a really useful biomarker that you'd be surprised how many people working in this area don't have would just be a structural scan of these kiddos to understand, where the injury is, how much cortical real estate they still have. And then we've started looking at things like laterality index. So I talked a little bit about how cerebral palsy, sometimes you see the activity on the opposite side due to the injury. You can look at how lateralized that activity is, and that's a biomarker that we think might help optimize rehabilitation, but still in its early stages.
Cool. Thank you so much.
Very nice talk, all of you. I have a question. We know that basically the brain is dynamical system that is closed loop, and I noticed that you're using open loop, and it seems cool. How well we understand the dynamic fluctuations in real life in healthy patients? Basically, I assume that the activity in these brain regions fluctuate over time as a function of context. So first we need to understand the context, and then we can use deep learning to better assess the context and close the loop in real time and have variability in the stimulation as the day goes on, and that might be more effective.
Yeah, I love that idea. I think it depends on what the time scale is that we need adjustments. Most of the device that can do adaptive stimulation right now isn't commercially available, number one, and two, it expects to need to adjust stimulation on the order of like seconds. Maybe for OCD, we need a device that can adjust stimulation over the course of like hours, days, weeks. So I think what this is going to require is new technology. But I'm excited about that future.
I have a question for Julia. You showed us the video that you played and the audio that you used to improve the subject engagement. And you said you found that it improved engagement with the task. I was wondering, how do you think about designing cognitive tasks or motor tasks that improve subject engagement in children without running the risk for potentially distracting, and whether you think that what you've observed is generalizable to designing tasks in adults as well?
Yeah, that's a really great question. So one of the things we're concerned with anytime we have a rapidly shifting stimuli or a flashing stimuli is that some of the activity you're getting is just related to the auditory or visual processing of that stimulus. So in the study that I presented today, we cheated a little bit by just showing the motor activity, but if we were, and we only had motor strip nears, but if we were to be looking across the whole brain, that would definitely be a concern. And in EEG especially, that's a concern, that some of the visual motor areas, you might be sort of conflating those two signals. So, and for our population especially, it was sort of a trade-off. Like some of these kids, because they are quite impaired, they have a hard time paying attention. So we made it as salient as possible with the loud noise and the flash. In adult populations or in typically developing populations, we might not need that so much to keep them engaged. So does that answer your question?
Yeah, thank you. All great talks. I want to ask a question that's really related to what David was mentioning, because it's very exciting to move from the lab environment to the real world. But there are also a lot of, complexity. One is like the technique itself, how you measure it. There's motion artifact or whatever. And also when you're in the real world, there's like more complexity in the brain signal itself. You need to disentangle. So I'm wondering like how much you do, for instance, like intermediate analysis, like I do in a simulated environment, or like I do some studies with head fix, but I'm still in a kind of a lab environment, but closer to the real world. I just want to hear your comments about how much we should, let's say, distribute our measurements, or so we can bridge this gap from the lab to a traditional lab to the real world settings.
I think that's an amazing point. I totally believe our efforts should be distributed from clinic to real world with maybe some intermediate environment. One of my big goals is to have an environment where patients can come in and stay that have DBS, kind of like the epilepsy monitoring unit, except there are no wires, so that we can get time domain recordings over the course of several days with more high resolution behavior than we can get at home. And I'm hoping that that will serve as the bridge to really understanding what's going on in the real world. But I think since the real world is so complex and so difficult to understand, these intermediate environments might be the answer.
Yeah, I think you said that perfectly. Again, it's kind of a trade-off between all these extraneous distractors and variables we're not controlling for in the real world versus I've been part of some paradigms where we've actually used virtual reality to try to do a more tightly controlled scenario, but that is not true gate and is going to be activating a slightly different set of processes. So I agree with you, more real world work needs to be done, but there'll always be that balance.
Yeah, and I think for us, so this is the first time that we've looked at these functional connectivity metrics outside in the real world or in the lab, and so taking a step back and looking at it in a more controlled environment would be really important, because right now, there's no way for me to know whether there was a car coming at you, and that's what really activated some sort of network, because I'm not accounting for that. And so looking more in a controlled setting would be really important, I think.
I want to argue for actually controlling for those uncontrollable things. So I think it's time for lunch. We have 2 hours now of posters, lunch, more discussions. This space is very conducive to discussions. There's some seating here with a nice view to the west. There's some outdoor seating actually just over there. And then there's seating in and amongst the posters. So please grab some food. And we have 2 hours. Look at the posters. There's 40 posters there. And let's thank our speakers again.